Isn't it great to be in such demand? So what we're going to do is we're looking at the area of the strengthened standards and the education around it and the implications it has on your workforce and therefore the risk to you. And Will, being the CEO of the largest training organisation in our sector and one of the largest in the health sector around the country, with something like 400,000 people on your systems? 420,000 people who go through the AusMed processes. I asked him if he could just give us a quick rundown of what the strengthened standards are all about, and then we're going to have a conversation, well, you're going to have a conversation with Tania about the standards. So over to you.
All right. Thank you very much.
Microphone.
I might stand up. So I'd like to
Thank you.
gesticulate a little bit. So I thought we'd just start by sharing some of the findings that we have as a provider operating at the scale that Kris just mentioned, and then take a lot of questions from the audience especially. Okay, so basically, click. Is that working?
Next slide.
I'd obviously like to acknowledge the traditional owners of the land upon which we meet. I think it's the Wurundjeri people where I'm from. I believe it's the Kaurna people up here in Sydney. Gadigal. Okay, Kaurna in Adelaide, that's right. Click, sorry, this clicker's not working.
Next slide.
There we go. All right, so we're talking about July 1st. July 1st, obviously being the date, that's the date that we're all working towards. The perspectives I want to share right now are really limited to the learning and development implications of the strengthened standards. So just imagine that lane, learning and development. And the, click again, sorry. I'll swap the clickers over. I'll keep going. The additional factor to consider here is obviously the new Act. So we're incorporating some kind of educational implications that stem from that. It was mentioned earlier in the talk from Minta Ellison around the definition of high quality care. So my contention really is, and this is the view of AusMed, is that the role of training, we hear workforce talked about a lot, but the role that training is going to play over the next 10, 20 years as the standards frameworks shift and the different initiative shifts of the Commission is to really systematically step the workforce up from a level of minimum care or minimum requirements being met to this definition of high quality requirements. I'll skip over AusMed, but as part of this, so in October last year, our clinical governance team came to me and said, we've got to be on the front foot for this. It's going to be a massive focus for 2024. Let's do a review of all of our content. We've got 1,200 modules in our library. We'll start with a gap analysis and try and work out what's missing. So what they've done on your behalf as well, I suppose, hence these insights, is poured over all of that information, including the guidance material that came through earlier in the year, and tried to boil it down to, if you were going to make educational requests or if you were going to have not met requirements or non-conformance requirements as a result of an audit from July 1 onwards, what would those educational requests show up at AusMed like? What topics would they be? As part of this review, we've identified 4 key changes. You know about this one, outcomes being the enforceable element, but it's mostly this next point that I want to really highlight on. We've picked up on at least 142 specific references to care and clinical skills, spreading across those 33 or 34 outcome statements in the new standards. There's also a much sharper language used around competence. So if you think about this progression of language, we've gone from compliance, someone's done the training, competence, that they're able to demonstrate they have the knowledge, to, in terms of the audits, the language of conformance, which really is defined as somebody or an organisation is displaying the behaviours that we expect them to be showing. AKA, the older person is receiving the outcomes that the new standards are advocating for. And the fourth is, and I pluck this out because of the 2 key words, effective and system. There's a number of references across this language around in action statements underneath each outcome, especially in Standard 2, around the performance of systems. So whether it's a clinical care system, an incident management system, a quality system, or a training system, there's a definition. We need to do some work in terms of, in our own organisations, or at least as a sector, defining the meaning effective, but also some work thinking about the role of a system. And the clue there is it's not just software. So 142 topics. This is what it looks like when we break it out across each of the standards. But I really want to zoom in on Standard 5. There's 75 specific references to clinical and care topics in Standard 5. Anybody want to have a guess as to why that one really has gotten quite large? You want me to just tell you? Well, I'll give you an example first. So this is what I mean by plucking those topics out. If we take an outcome 5.3, medication safety, this is the specific outcome statement dealing with medication overall in aged care. We're at least picking up 14 training topics. This doesn't include all of the nuanced terms or topics that we're starting to see. We had a really unusual one, which is anticipatory medicine is referenced in the new standards. I haven't heard a good definition of what that is yet, I've got to say, and I'm asking everybody, so if you know, come and chat to me afterwards. But anticipatory medicine, that's not on our list, but it's specifically mentioned in the standards. What is that? So the reason for this is that in recommendation 13, a component of that was effectively this item 1 here, which was that the Australian Commission on Quality and Safety in Healthcare, which is the hospital regulator, actually be involved in writing the aged care standards. Now the recommendation was that they wrote all of the standards. That wasn't accepted. However, they did write Standard 5, right? So I heard it kind of brought up earlier that there's, when we talk about workforce and the skills gaps and the training that's needed, this is really what we're talking about. We heard terminology like a subacute, residential becoming a subacute setting. We know in a residential environment, we might have an average stay of 18 months and declining over time, really attesting to that acute nature of the resident who's in the service. Clinic. So how close is that environment getting to a hospital setting? Well, according to the Australian Commission on Safety and Quality Healthcare, that regulates hospitals as well as other allied health and community care services, it is quite close. It's so close. It's worth actually listing the Aged Care Quality Standard 5 as a standalone standard on their website, claiming that that's something they're now concerned with. Right? This is a separate listing to the Aged Care Quality Safety Commission's listing of the standards as a whole. So some interesting things playing out here. So I mentioned earlier, we've made a gap analysis tool. We identified 142 items. We think that's conservative. I just wanted to make that point. You will definitely be doing training across a whole lot of those areas already, and you would have a workforce that, let's just work under the assumptions, is safe in a large majority of them. But my question to each of you, and maybe some of the questions you might fire to us, is where the gaps exist, and our way of thinking about that is what is high priority and high risk. And the high risk is really a euphemism for a sentinel event or some sort of, if care was to be missed or provided incorrectly, that it would lead to harm. What are those in your own organisations? What are the unique gaps that you identify that could manifest as risks? So if I say to you, you've got 142 topics to provide training on, and you determine that maybe 10% of them are high risk and high priority, how are you approaching that training from July 1 onwards, or once the new standards are in place? I'll skip over all this and I'll just get to this bit here. So what we're seeing is, and I think we're probably in conversations with at least 7 or 8 of the top 10 providers now, and we see them on these committees, these standard rollout committees. We're seeing a structure that looks like this. So we have in the blue box a big group level project committee, lots of people involved, and they're coordinating subgroups or working groups underneath that across 3 areas on the left, which really talk to standards 5, 6 and 7. So specifically around clinical care, environment and food and nutrition. But then obviously these other 2 groups, risk and compliance and training. AusMed's perspective is really down at that training level. I'll fast forward, last slide, and then I'll fast forward to the Q&A bit, just mindful of the time. What we're really encouraging is, we heard from Commissioner Anderson on the 5th of February, I think it was, at a webinar, that providers will be expected to be compliant with the new standards from July 1 onwards, or as soon as the Act comes into effect. Let's at least say that the entire workforce needs to know they exist and know what they entail by that point in time, which means training on the new standards really is going on now. Some of those bigger providers that I mentioned earlier, their training plans are kicking off on the 1st of April with kind of a global assignment of modules on what the new standards are, maybe one on the new Act as well. But it's really that July 1st onwards period when the audits commence, where we're interested in seeing, and we get to see this at the footprint that we have. We anticipate, across maybe 20-25% of the sector, when we start to see those audits, that it'll be focused on these high-risk, high-priority areas. So using that gap analysis, you can identify those in advance and have that training plan ready to go as well. So I'll fast forward through all this just because of the time and get to one last slide actually here. So I think at the very least you want to be reporting against these in your training and probably all those other areas, risk and compliance and other at an outcome level. If there's an audit that takes place, step one is a request for information, provide evidence of the system that you run to meet that outcome, and then provide evidence, so a statement, an outline of how your system's designed, and then provide evidence of the system actually being run. A form of evidence will be training records or policy compliance or things like that. It'd be a bit of a nuisance to get to that moment and realise no learning has been taking place in those areas, especially that the audits are happening now at an outcome level. They're very, very specific. So I think reporting at a board or governance or governing body level, at least at an executive level, on activities across risk and compliance and training at an outcome level is a critical kind of change. So if you scan this code, you can download that gap analysis. It's a QR code. And obviously we're happy to, field your questions and that tool's free. It's about 600 to 900 hours of 2 clinical nurse specialists' work over 3 months. So hopefully it gives you back that time in your own program.
So if I can just repeat that, because when we did the walkthrough of this situation last week, you have the opportunity to get that gap analysis document gratis.
Absolutely, yep.
Because AusMed has done the 3 months by 2 people thorough analysis. Yeah. And if you didn't have 3 people who know what they're doing for 2 months, you would not be aware of the landscape you're facing, and you could be exposed.
Absolutely, and I think it's just how do you eat an elephant one bite at a time? If we're saying there's 142 potential training items or areas that could manifest as risk, wouldn't it be great to get to a point where you know which 10 of yours are the ones you're going to work on first because they're high priority? So that's the point of that document.
So before we take questions from the audience, Tania, you're at the coalface. Just quickly tell us, with IRT, you provide training not only for your own organisation but for people outside, don't you?
We do. We also have a registered training organisation, but I've worked very closely with AusMed for a number of years now, and off the back of the conversations this morning, what we've been doing at the coalface in having really quite mature learning and development strategies in place, the models that sit behind it, bringing in then the tech to have that, both the depth, but really importantly, and when we're throwing out numbers like 142 education requirements, I just sat there and just went, oh, that's a lot. How do you, there's certainly data you're going to use to prioritise, to Will's point. But how do you do this in a way that's scalable, but really importantly, meaningful, that it's going to translate into a behaviour change. It's going to translate into, and I'm going to just call it out there, I really don't like the word conformance. I'd rather say that we're talking about performance in the industry and how we're performing at a high level. So, sorry, I just went off the track then.
That's a good point,
yeah,
though.
But in terms of, coalface, we most certainly, are using the AusMed gap analysis tool. It's just saved us a load of time. It's fantastic, right? But we're also now looking at our existing training models. Like I said, we've had them running across all of our core roles, across all of our business streams. So we have residential aged care, retirement living and home care, so that every core role has an education plan, excuse me, that brings in annual competencies determined by what we've determined as our mandatory, as well as aligned to what's a data-driven model. So where we've got areas of risk, priorities, as well as then the AusMed library. We still do some of our own bespoke development, so we're ensuring that, again, we're getting that knowledge base scalable, because I have one rule with my education team, to get staff into a training room, the resource that sits behind it, the resource that sits within it. There's pretty much one big rule that I have, capitulated on the odd occasion: no PowerPoint. That's why we do have online learning. That's where and really good quality online learning. So when we get people into a training room, I want them undertaking, like practical learning and really engaging. So that's what we're doing at the coalface.
It'd be interesting to know how many people in the audience do training by PowerPoint. No hands up. So do we have any questions in this area before I ask a question or two? So Tania, the speed of new regulation, how do you cope with that? And what's your advice to the room, just to be aware of what's coming through and how to cope with it?
Yeah, I suppose from a planning perspective, we start our forward planning for our annual education in August every year. The team just know August, here we go. We're going to start doing all of our internal consultations. We'll also be doing the environmental scan. We're certainly not sitting, in a hole for the previous year. We know what's coming. And so we will plan ahead so that all of the plans have, even if they've just got a placeholder, and I know this might sound quite tactical, but it's how we do it. So that we knew that the new aged care standards were coming out this year. So we already had that baked into the plan. And what we were already anticipating we would need to do to gear up the workforce. And to Will's point, the first thing is always awareness. And you know that as soon as you're starting to get audited, it's going to be it'll be one of the first questions you get asked in terms of education. What have you done about the new standards? Right, here's our plan, this is what we're executing. And as soon as the modules, and this is why we do work with partners like AusMed, because I had the conversation with Will, and it was one of our early conversations last year, which was, when will AusMed, are they going to be ready to have content for the new standards? Because we're already thinking ahead, right, where are we going to source that, where we get it to a high quality and then a standardised content? We're trying to avoid, it's a last resort if we're designing or developing our own online content. We'd really try to avoid it. So
you're a very mature learning and management service within IRT and the Illawarra. Will, with your client base, how prevalent is a mature department or facility like Tania's?
I think it's a good question. I think, so there's two drivers, potential drivers for education. One is obviously regulation, and that's kind of non-negotiable. Everyone has to do that. The second is the ambition of the organisation. And I think at this conference in particular, it's the desire to grow the business. And inherent in that ambition is an assumption that you have a workforce who's able to execute on that strategy at every single level in the organisation. So I think in sectors that are less regulated than health in Australia, the way, and I think you used to work at Toyota, is that right? L&D at Toyota. So step one is you come up with that competency framework. You come up with a definition of what good looks like. And then you look at the ways that you're going to elevate the workforce to meet that need so that such that the business can grow. In health, because we get given a standards framework, that step in the process is often overlooked. And we just go straight to teaching what the regulator wants us to teach. What we're starting to see is a swinging back the other way. And I think to Tania's point, spending that custom effort on things that are unique to the provider, unique to the business model. So in the panel previously, we had Simon and Kris. Simon from 5 Good Friends, and I always get their home care names right at home or home instead. Home instead. That's right.
Home
Instead. Talking about that focus, that they define a capability framework for their own workforce. What is the 5 Good Friends way? What is the home instead way? And what extra effort of training is going on there? Maybe 2 good examples of this I really like is from Infinite Care. They run a podcast called Honey, We Grew the Team. It's great, and it's a higher growth organisation. That's a way to disseminate culture. It's non-mandatory, but there's a huge level of engagement. And they also run a TikTok account sharing stories about kind of care across their different services, residential services. I think IRT has a good innovation in this space as well, which is an advanced care worker role, the aged care educator.
Yes, so we've implemented a 2-tier education roles, and we kicked that off last year, and it's been really successful. We were finding, as I think, I feel like it's a bit of a broken record to talk about workforce challenges, but here we go. So we were seeing, very high turnover, in particular in the first 12 months of a care worker's tenure. And when we were unpacking that through exit interviews and so forth, it was really that, really the absence of good pastoral care. So we've implemented a more junior educator role. I'm sure it's not unique just to us. I'm sure it happens out across the sector. But we've found that to be a real game changer. When I was telling the CEO why this model was really important and putting up the business case around it, and he said, well, but we've got clinical nurse educators. I said, rightio. Our clinical nurse educators observed people washing their hands 6,950 times last year. I cannot really justify that. Justify the skill level that a clinical nurse educator brings to work every day to watch somebody wash their hands. Understanding as we do how much infection control is important. But we can get other people to be doing that, and then we wrap around in those competency assessments. We've, by design, been building in, like we'll do an on-the-spot coaching session around infection control while the person's washing their hands. So that more junior level has been fantastic. They're also then scooping up our new hires, our trainees, and providing also that kind of that pastoral care and that glue, so to speak, to support people. Coming on board into the sector, it's hard graft. I'm sure we're all very aware of that.
Well, I think we've actually come to the end of our time as I see the next audience is moving in, but the net result is the new standards are far more complex than most people appreciate. There are many ramifications within each standard, and it's important people get to understand that and develop a pathline. As you said, they can't be expected to have everything under control from day one, but they've got to at least demonstrate that they're on the pathway. Is that a fair statement?
I think so, and at least have a plan, or at least know how big the problem is. Have some specificity around that, where they may start.
Then they've got something to say.
Yeah.
Okay, can we show our appreciation for the panel? Thank you very much. Thanks, Will. So we're just going to do a quick change over for those people who wish to